The human brain operates at a massive metabolic deficit. It claims up to 30% of total cardiac output to function, yet it stores almost no energy of its own. When oxygenated blood stops flowing, its operating capacity is immediately exhausted. This sudden drop of systemic perfusion to zero defines cardiac arrest. The heart's organized mechanical activity stops, halting the delivery of oxygen and glucose to tissues body-wide. CPR is an aggressive, artificial hemodynamic intervention designed to preserve multi-organ viability. By manually compressing the chest, a rescuer forces a temporary state of blood flow. It is a strictly mechanical bridge, sustaining cerebral and myocardial tissues until definitive therapies, like electrical defibrillation, can be administered. To execute modern, standardized clinical protocols effectively, we have to look past the surface-level instructions. We need to trace the biology of ischemia from the microscopic collapse of a dying cell all the way up to gross thoracic biomechanics. Every compression is an attempt to outrun cellular decay. Without this physical override, the structural integrity of the brain and heart will fail irreversibly within minutes. Seconds after circulatory arrest, the brain enters a metabolic crisis known as neurogenic hypoglycemia. This diagram shows a neurocell membrane as adenosine triphosphate is depleted. Without ATP to fuel the electrochemical gradient, the sodium-potassium pump freezes. Sodium floods in, causing osmotic swelling. Simultaneously, a lethal calcium overload activates degradative enzymes, consuming the cell from the inside out. This ionic chaos forces the release of excitatory neurotransmitters, most notably glutamate. The brain effectively poisons itself through a process called excitotoxicity. Clinical research divides this damage into two pathways: accidental cell death, caused by immediate physical trauma like osmotic swelling, and regulated cell death, which includes programmed signaling cascades like apoptosis and necropoptosis. The development of severe membrane permeability defects marks the transition from reversible cellular injury to permanent structural collapse. In the heart muscle, this manifests as coagulation necrosis. Myocytes rupture, releasing proteins like troponin into the bloodstream, the diagnostic marker of severe ischemic injury and myocardial infarction. Left uninterrupted, this microscopic cascade guarantees catastrophic organ failure. The only way to halt it is an immediate physical override: manual, artificial circulation. Gross manual force applied to the chest can counteract this microscopic decay. By manipulating human anatomy, a rescuer can generate artificial blood flow. This cross-sectional model shows the structural model between an infant and an adult. These differences determine which of the two primary scientific models of artificial circulation is doing the work: the cardiac pump theory or the thoracic pump theory. In the infant model, the cardiac pump theory drives compression. The ventricles are squeezed between the sternum and vertebral column, ejecting blood. During decompression, the chest recoils. Ventricular pressure drops, valves open, and venous blood fills the empty chambers. In the adult model, we see the thoracic pump theory. Direct cardiac deformation is less prominent. Instead, compressions increase global intrathoracic pressure. This pressure gradient pushes blood outwards, while venous valves at the thoracic inlet act as one-way gates preventing retrograde flow. An infant's cartilaginous, flexible ribcage allows for direct manipulation of the heart, relying heavily on the cardiac pump mechanism. Conversely, a rigid, ossified adult ribcage resists direct heart compression, making the thoracic pump mechanism the dominant driver of blood flow. Effective manual perfusion requires manipulating gross anatomy to recreate complex hemodynamics. Because skeletal structure changes so drastically with age, the physical technique used to generate that pressure must change with it. The American Heart Association translates these anatomical realities into actionable clinical protocols. This table compares the technical standards for adult and infant CPR. Adult arrests are primarily cardiac in origin, whereas pediatric arrests frequently result from respiratory failure, creating a massive physiological need for prioritized ventilatory support. Moving to compression depth, an adult's fully ossified skeletal structure demands intense manual force to achieve the required intrathoracic pressure, dictating a depth of at least 2 inches. An infant's cartilaginous ribcage is highly susceptible to internal injury. To avoid trauma, the two-thumb encircling hands technique is required, limiting compression depth to just 1.5 inches. Airway management also shifts. Adults require a full head tilt to open the airway. Infants have narrow, easily obstructed airways, requiring a neutral or sniffing position to prevent kinking the soft tissues of the neck. Infants are not simply small adults. Applying rigid adult force and techniques to a pediatric patient fails to address the underlying respiratory failure and induces lethal physical trauma. In every cardiac arrest, the primary adversary is no flow time. This graph charts survival probability against minutes elapsed without intervention. For every 60 seconds of no flow time, the chance of survival decreases by 7 to 10%. This decline mirrors the cerebral category scale, measuring outcomes from CPC-1, good cerebral performance, to 4, vegetative state. By 10 minutes, probability shifts sharply towards CPC-3 or higher, representing severe disability or brain death. Immediate bystander CPR actively alters this trajectory. Providing artificial perfusion during the no-flow window doubles or even triples the patient's probability of survival and a favorable neurological outcome. Given the intense physical demands of maintaining depth and rate, it is logical to assume that automated mechanical CPR devices would outperform human compressions. Clinical data proves otherwise. Large-scale randomized trials have consistently shown that mechanical CPR provides no survival benefit over high-quality manual compressions. When traditional methods fail, modern medicine relies on eCPR, routing the patient's blood through a portable heart-lung machine to bypass the static heart entirely. However, this procedure is highly invasive and carries significant risks of severe hypoxic ischemic brain injury. Despite the persistent allure of advanced automation and complex perfusion technology, rapid, high-quality human manual compressions remain the definitive gold standard for preserving cerebral tissue. This minimalist model illustrates the 2025 six-link chain of survival. The guidelines consolidated separate in-hospital and out-of-hospital models into a single framework. Because cellular ischemia remains identical regardless of location, the heaviest burden falls on the immediate pre-hospital layperson response. Yet, execution is hindered by the bystander effect. The psychological diffusion of responsibility, coupled with an intense fear of causing internal damage like rib fractures, frequently paralyzes witnesses during the critical no-flow window. The massive public deployment of automated external defibrillators is designed to mitigate this exact hesitation. They provide clear voice guidance, ensuring civilians act decisively. To strip away the final barrier, Good Samaritan laws provide legal protection. Rescuers are shielded from liability for injuries sustained during resuscitation, provided their actions are voluntary and free of gross negligence. Cardiopulmonary resuscitation exists at the intersection of circulatory physics and cellular biology. Continuous, precise force applied to the thorax allows a rescuer to override the ischemic cascade, making survival possible in scenarios that would otherwise end in biological death.